Hello everyone, today's topic is on cystic fibrosis. It is also known as mucoviscidosis. Let's see the outline of this disorder, what is it and what are the clinical features. Then we'll go in detail about the pathogenesis and what are the reasons for those clinical features. Okay. The first is, what is cystic fibrosis? It is an inherited disorder of ion transport. Because of the inherited disorder of ion transport, there it affects the fluid secretion in exocrine glands, in respiratory tract, in GI tract, in reproductive tract. So there is, I told you, fluid secretion defect. The fluid which is secreted is very thick. So because of that, it will obstruct the organ passage, thereby resulting in different clinical features. So what are the clinical features? Chronic lung disease, pancreatic insufficiency, intestinal obstruction, cirrhosis, male infertility. We'll see why all this occurs. Okay, once you know the pathogenesis, then it will be easier to know all the clinical features. It occurs before birth and later in childhood also it can present, or in even an adolescent. It occurs 1 in 2500 live births. In cystic fibrosis, there is abnormal function of the epithelial chloride channel protein. This chloride channel protein is encoded by Cftr gene. What does Cftr stand for? Cystic Fibrosis Transmembrane Conductance Regulator Gene, which is present on chromosome number 7, long arm 31.2. What does this Cftr gene composed of? The structure of the Cftr gene is, it contains 2 transmembrane domain, okay, and 2 cytoplasmic domain. This cytoplasmic domain is nucleotide binding domain, and a regulator domain. This contains protein kinase A and C. Remember the structures. Okay, 2 transmembrane domain, 2 cytoplasmic domain, which is a nucleotide binding domain, and a regulator domain which contain protein kinase A and C. Now what happens? An agonist, or it is acetylcholine, let's say. Okay, acetylcholine comes and bind to the epithelial cell of respiratory tract or GI tract or whatever epithelial cell, it will come and bind, an agonist. So what happens? There is increase in cyclic AMP, which will activate protein kinase A. We know that protein kinase A is present in regulator domain. So what happens? There is phosphorylation of regulator domain. This results in hydrolysis of cytoplasmic domain, that is nucleotide binding domain. Thereby there is opening and closing of chloride channel. This is the structure and function of this Cftr gene. Now you have to remember one more thing. To understand the pathology or pathogenesis of cystic fibrosis, it does not just control the chloride channel. It has multiple additional ion channel like potassium channel, epithelial sodium channel, and bicarbonate. Now comes the beautiful story of pathogenesis. So if you understand this entire cystic fibrosis, you can write. So right now, don't get confused. I am talking about sweat glands. Normally what happens? So normally in sweat glands, so this is a lumen, okay. This is epithelium. These are epithelium. So these are epithelium and lumen. So normally in the sweat gland, the chloride and sodium are reabsorbed. So sodium and chloride are reabsorbed. So whatever the fluid secreted in the lumen will be isotonic. This occurs normally in sweat gland. Now we'll see in cystic fibrosis in sweat gland what will happen. So Cftr mutation occurs. So in sweat gland, the normal resorption of sodium and chloride doesn't take place. So what happens? This sodium and chloride are secreted into the lumen. So whatever the secretion in the lumen will be hypertonic. So normally in the sweat gland I am talking about, sodium and chloride are reabsorbed. So the secretion in the lumen is isotonic. Whereas in CFTR mutation in sweat gland, there is sodium and chloride are secreted into the lumen. So whatever the secretion in the lumen are salt and sweaty. So the first symptom the mother detects in an infant is salty sweat. This is the reason for that clinical feature. Now, the story doesn't end here. It is not that simple. You have to know the function of the Cftr gene is tissue specific. So, whatever the mutation of the Cftr gene is also tissue specific. What do you mean by this? So, now we will see normally what happens in respiratory tract, GI tract. This is normally I am talking about. Now the sweat gland story is over. Now what happens in respiratory tract and GI tract normally? Normally the chloride is secreted into the lumen in respiratory tract and GI tract, whereas sodium and water are reabsorbed. Okay, this occurs normally. Now in CFTR mutation in respiratory tract and GI tract, what happens? The function of the chloride channel is lost, so there is decrease or loss of chloride secretion. So chloride is almost reabsorbed. There is no or loss of chloride secretion. Also there is active sodium and water absorption from the lumen. Okay, so chloride is also absorbed, sodium and water is also absorbed in case of CFTR mutation in respiratory tract and GI tract. So what happens? All the ions are reabsorbed. So whatever the fluid will be of low water content or isotonic. So to revise the sweat gland, in the sweat gland story, in case of CFTR gene mutation, there is hypertonic secretion in the lumen, whereas in the respiratory tract and GI tract, it is either isotonic or low surface volume fluid in the layer. So normally in respiratory tract and GI tract, there is secretion of chloride into the lumen. In CFTR mutation, there is decrease or loss of secretion. There is more of resorption of the chloride. Also there is active sodium absorption. Along with that, there is increased water reabsorption. So chloride, sodium, water, everything is reabsorbed in respiratory tract and GI tract in CFTR mutation. So the solution or the secretion in the lumen is isotonic, or it contains less of water. So in lung, if you see what happens, I told you in respiratory tract, mutation of CFTR gene results in decreased water or isotonic solution. So it is a dehydrated luminal surface. So there is defective mucociliary action. Therefore the secretion is thick because water is not there. It is reabsorbed. So what happens? Because of this thick secretion, there is obstruction of the passage. Later, because of this obstruction of passage, there can occur secondary infection by various bacteria. The story doesn't end here with chloride channel with sodium channel. Next comes the hero, bicarbonate channel. So normally, because of this bicarbonate channel, bicarbonate is secreted into the lumen. So into the lumen, bicarbonate is secreted. So whatever the secretion in the channel will be alkaline because bicarbonate is there. In case of cystic fibrosis, in case of CFTR mutation, what happens? This secretion of bicarbonate doesn't take place. So in the lumen, what happens? There is decreased bicarbonate. So the fluid in the lumen is acidic because of decreased bicarbonate. So this mainly occurs in pancreas, remember that, okay? In bicarbonate channel, what happens? There is acidic fluid. So bicarbonate channel mutation, there is acidic fluid, there is decreased luminal pH, so there is precipitation of the mucin. This results in plugging of the ducts, so obstruction of the duct. Later there is secondary infection. This is almost always occurs in pancreas. So this is characteristic features of cystic fibrosis involving the pancreas because of bicarbonate channel defect. Occurs in Cftr gene. There is defective protein synthesis, there is abnormal protein folding, there is defective regulation in the gene, there is decreased conductance of the gene or reduced abundance or altered function in regulation of ion channel. These are the mutations of Cftr gene. Now, because of all this, we know pathogenesis, we know clinical feature. Now, if you take this organ histopathology, what are the morphological changes you will see? So, first coming to pancreas and salivary gland. So, the ducts, we know that it is plugged because of decreased luminal pH or because of acid secretion. So, it can be either dilated or it can be atrophy. Later progress to fibrosis, and there could be squamous metaplasia at focal places can also be seen. This is seen in pancreas and salivary gland. Now, what are the morphological changes in the liver? Again, the bile canaliculi are plugged or obstructed. There is ductal proliferation is seen, and there could be portal inflammation. So later progress to focal biliary cirrhosis. This occurs in liver. Now you know why the liver changes are seen. Now lung, this is very important because it is the most serious complication that occurs in cystic fibrosis is in lung. The bronchioles are distended, okay, and also there are thick secretion or thick mucus secretion. There is marked hyperplasia and hypertrophy of mucus secreting cells. There can be superimposed infection which results in chronic bronchitis, chronic bronchiectasis, in some cases lung abscess, and because of opportunistic bacteria called bacteria cenocepacia, a fulminant illness occurs that is known as cepacia syndrome. This occurs in lung. Now, sweat gland, if you see the morphology, there is morphologically no changes is visible. Apart from that, if you take reproductive tract, male infertility is seen because of azoospermia. Also, in many cases, congenital bilateral absence of voice difference is also seen. This is about cystic fibrosis. We know what is cystic fibrosis and what are the clinical features and what is the pathogenesis of cystic fibrosis and what are the morphological changes in each organ in cystic fibrosis. Thank you.